So for our last talk, we'll have Dr. Cohen, who will talk about patch testing in atopic dermatitis patients. We've already seen that many patients have allergic contact dermatitis. When should we patch test them? Impact of flares and systemic medications.
All right, you had your chance to get out at the break. So I think the other speakers alluded to this, but these topics are a little bit difficult to prepare for because they're not routine things we speak about, but they're clinical scenarios that occur all the time. And kind of a true story. February 40 years ago, I went on my first date with my wife, right? And we've been together. And I cannot count the number of times she has called me a fool over 40 years. And 2 weeks ago, as I'm hunched over the computer trying to put this talk together, I said, she's right. Because this is a very unusual topic that comes up in the clinic all the time. And for industry, you are going to be asked the question whether your drug has an impact on patch testing, and you'll look bewildered at the question, and of course will just send us the package insert, right, with few studies to actually answer the question. And there's nothing wrong with your MSL or with the data you have. There's no good answer, right? So this is an interesting and important topic, but it is mired in contradictory data and old dogma. These are my disclosures, and we'll also be discussing at times non-FDA approved allergens. So to start off as well, look, these are the eczematous dermatitis, right? Atopic, irritant, and allergic dermatitis, nummular, dyshydrotic, id, and I dare say spongiotic drug eruptions. But contact dermatitis, that's the hubris of eczema. It's the swagger and pomposity of spongiotic dermatitis because we patch test and we believe we have determined the cause of an eczema, where all those other dermatitis there, we don't really know the cause. But there's a big chasm between having some positive patch tests and proving that that patch test is the cause of the dermatitis you're looking at. And to make things worse, all of these eczemas clinically look the same, right? They're red, they're infiltrated, they get excoriated, they're lichenified if they're chronic. And then when you biopsy it, it comes back spongiotic dermatitis or psoriasiform spongiotic dermatitis, and you're given this menu of options as possible differential diagnoses. So it could be really difficult for us to determine what the real causes are. And you heard very sobering and convincing evidence that atopic dermatitis has perhaps a comorbidity of allergic contact dermatitis. Right? It was a great talk hearing that. And here's just some data that kind of reiterates that. And some AD patients defined as difficult to treat, meaning failing 2 or more topical therapies. 3/4 of this group of 48 adults and children were positive on patch tests, and almost 40% of them had positive patch tests to multiple allergens. And they were surfactants and lanolin and fragrances and metal. And we looked at this a couple of years ago, tried to look at all the data, and we came to a conclusion that there was a preponderance to suggest that atopic patients have some increased risk of allergic contact dermatitis, particularly to the allergens you heard about, like lanolin or from sheep fragrances, preservatives, and steroids. What I found really interesting, almost numbing, right, this North American data that came out just a couple of months ago. When we patch test, we tend to use standard series, right? There's a European standard series. The North American standard series has 70 allergens in it. And when the North American group looked at atopics who were patch tested to a standard 70 and supplementary allergens based on the clinical history, do we add cosmetics, do we add more fragrances, do we add textiles, 1/5 of these patients had reactions to number 71 and higher, not even captured by the standard 70. And those at greatest risk for supplementary allergen positivity was atopic patients. So there's a real broad spectrum of what we have to think about in atopic patients. Now, for some of you in industry, it may not be routine to see what a patch test is, but how this works is the allergens come in syringes or bottles, and we use internationally standardized concentrations in an attempt not to be too high and irritating, but the right concentration to detect allergy. So they're put in these chambers that are either plastic or aluminum. They're placed on the back, no needle sticking or scratching. So patients like that part. We tape them on, we supplement the tape, and the patients go home, and about 2 days later they come back and we remove them. We map the allergens so I know where number 2 is and number 87 is on their back. You can't get that part wrong. And we do a preliminary look at it, and then 1 to 4 days later, we do a final reading. And remember though, this type of allergy is delayed type hypersensitivity. This is not like the peanut causing your eyes to water and your throat to close. This is delayed. So here's some metal allergens, and on the left, we see some positive reactions to palladium and vanadium, and nothing going on in the 50 series, absolutely nothing. But a couple of days later, we see nickel and cobalt emerging, right? So this really takes some time before you see a clinical response. And as I mentioned earlier, this overlap clinically is sometimes impossible. This patient was sent to me what was seemingly mild atopic dermatitis, right? Antecubital fossa involvement. There's always that one finger you can't get clear, right? It's always that stubborn one, a little bit on the neck, like pretty good referral, and they thought it was contact dermatitis, thought it was AD, and this is her back, filled with reactivity to methyl-isothiazolinone, tosylamide formaldehyde resin in her nail polish, and in fact, avoidance of allergens caused her to become nearly clear. So what looked all the world like straight atopic dermatitis was shockingly contact dermatitis. But I suppose the difficulty of this topic is, are all of these diseases caused by allergens the same? So is that nickel-induced dermatitis on the abdomen, is that the same disease as the bacitracin-induced eyelid dermatitis, or the cocamidopropylbetaine, the soap surfactant from shampoo? And are these patch test reactions all caused by the same mechanism? Some are blistering, some are just red, some cause pustules, some are irritants on the edge effect here. And here's one patient with reactions to sort of different classes. Little action with induration to fragrance. Nice reaction to propylene glycol. Gold is expanding, and cobalt looks positive. That's probably an irritant reaction from hemorrhage in the sweat gland that cobalt does. And we know that there's pustular reactions that can happen to metals. So are these the same? And I would suggest that Emma and many others have poked us to say they're not all the same. Now let's layer in the subject matter. Is systemic medication influencing the patch test reactions? Well, systemic medications is an awfully large term, right? In 2014, the AED had the guidelines of care, and the key systemic medications for eczema were cyclosporin, methotrexate, mycophenolate, and azathioprine. And those have different mechanisms of action, but we would consider pretty broad immunosuppressives. And now we have medications that are as narrow as just IL-13 to as broad as pan-JAK inhibitors or selective JAK1 inhibitors that have been approved. So you have the polymorphous nature of the patch test allergens, which are numerous and are in the hundreds, and you have this broad area of immunosuppression or immunomodulation. So when I give someone a pill or a shot, will all of those different allergens be affected equally? And I'd suggest probably not. The colloquial view of contact dermatitis has been Th1 allergy, right? And it's based on mouse studies of isocyanates and dinitrochlorobenzene, and that's been the view for decades, right? And Emma mentioned it, and her group and some others have suggested patch test reactions are not uniform. They're not homogeneous. They involve Th2 immunity, Th22, sometimes Th17. And so you're looking at multiple variables on top of multiple variables. And sensitization is going to be related to the host and the type of exposure. And I've listed here that some of these are different. There's some data that methylchloroisothiazolinone is a Th2 polarized allergic contact dermatitis, not Th1. So how do we get through this dilemma? And then we'll layer in that contact dermatitis, like all other eczema, is very itchy and has IL-31 involved in it, although it doesn't seem to be allergen related. It's just the elaboration of an eczema from contact dermatitis does it. And IL-33, we certainly see in atopic derm and in mouse models is involved in poison ivy, which is a very tricky allergen to generalize to other allergens, right? The sesquiterpene, lactones, and urushiol, they're difficult. So let's just dive into it. There are some studies, albeit small, that look at patch testing while on systemic medications. This one, published in February last month, for methotrexate patients, right? So overall, out of a group of over 600 patients, their positivity rate is about 50%. That's a pretty decent international standard, that when you put enough patches on someone you suspect has allergic contact dermatitis, about half the time you ought to expect a positive. And then when you go into the medical centers, the numbers creep up a little bit because they've been pre-screened. You have some epiphenomenon there where you have a higher risk of allergic contact dermatitis. So about 62 of this group were taking methotrexate, and you dive in, they're taking a good dose, 15 milligrams. They have cumulative doses of over 250 milligrams, so they've been on it for a while. And the conclusion is no difference in how long they've been taking methotrexate with positive or negative results. Okay, so the dose and the length didn't make a difference. And the conclusion is that the methotrexate patients had no discernible difference in the number of patch tests that were seen, and that there weren't probably false positives. And what they're doing in most of these studies is counting positive patch tests and counting the quality of those positive patch tests. So you see methotrexate group, control group, 1+ reactions, 2+ reactions, and 3+ reactions. And I'd submit that there's some issue with that, right? So here's 3 units of something, 3 gold bars, and here's 3 units of something else, right? They're not the same when you have just 3 of something. And then when we dive in to look at the groups, you see that the control group has the top 5 allergens, 3 of them are metals in the control group, and yet the top 5 allergens in the methotrexate group only have 1 metal, and fragrances float to the top. Now, how do we reconcile that? One, the patients who you put on methotrexate may not be the same patients that you don't have on methotrexate, and so that may be the implicit difference. And is there a class shifting? Does methotrexate suppress some and let others come through, or even encourage positive patch tests to other things? So I would say, yes, you're going to be able to get positive patch tests when you have someone on methotrexate, but it may not be the same as the naive patient getting patch tested. The recent systematic review of immunosuppressives, and they looked at a number of studies, and about 85 patients got evaluated where they had pre and active immunosuppression, where they were patch tested before and during going on these drugs. And for dupilumab, about 2/3 of the 2+ to 3+, and in layman's terms, those are robust positive patch test reactions. They were preserved. Now that sounds great, but 1/3 weren't preserved, right? So there's an issue there. Azathioprine had been studied before it was started and during its treatment for Parthenium. Parthenium is a plant, it's a compositate plant, a particular problem in India causing airborne contact dermatitis. It's a robust, parthenin is a sesquiterpene lactone, and it's a potent sensitizer, and it was hard to suppress reactivity to Parthenon, right? But it's like saying, putting a rubber glove on and sticking your hands in the freezer doesn't really protect your hands from getting cold. When this is being challenged, it's hard to suppress. Cyclosporin at 5 milligrams per kilo per day, that's on the higher side of therapeutic dosing, suppressed half of the positive patch tests, right? Some will break through, and you might say, great, those might be the most relevant ones, but you'll never actually know that while they're on therapy. And there was an oral presentation this morning about prednisone in patch testing, and even 5 to 10 milligrams will have a small but measurable impact on patch tests, largely in the 1+, the minor reactions. But for those that patch test, we kind of live by the 1+. The 2+ and 3+ gets us very excited, right? And they're not so common. Like, we get worked up when we see 3+ reactions, right? We got to sit down, take a breath, and then we move on. So losing 1+ reactions are important. Now let's look at dupilumab for contact dermatitis, and it's usually in the context of patients that have atopic derm. So here's 64 patients given dupilumab, and a quarter of them had contact derm confirmed by patch testing, although the relevance is unclear. A quarter had suspected contact derm, and the other half didn't have contact derm. And they weren't able to see a difference in the qualitative response of the drug in these patients, suggesting that it seemed to be working for the allergic contact dermatitis group as well as the AD-only group. And then there's a small group of patients who had dupilumab and underwent patch testing. One had been patch tested before and had lost multiple positive patch tests when they were rechallenged on dupilumab. And this study suggested that dupilumab did help with the atopic derm and the allergic contact dermatitis component in some patients, but not in all of them, particularly if they kept having exposure to the allergens. So we could further this along a little more. This is another systematic review, 72 patients. Took 19 studies to get to this number, and a few of them reported on the direct impact of dupilumab on patch testing. But when they mention here that a number of their patients with allergic contact dermatitis cleared, and some didn't clear, right? Now, what about on the patch testing? They actually were able to get 22 patients together that had paired testing before dupilumab and during dupilumab, and they noticed 17 allergic reactions were lost. They couldn't get a positive patch test. 8 were new, and 71 persisted. So their conclusion was it really depended on the allergen to determine whether dupilumab was going to have an impact. So is this typical for patch testing? Shouldn't it be reliable? You test to someone in July and then test them next February. What do you expect to see? I had to go back 25 years before there were systemic therapies widely deployed for atopic dermatitis, looking at patch test reliability. This is an Italian study, and they had 174 subjects that were patch tested within about 5 years of the prior patch testing. And there was no systemic therapies complicating this. So 18% had one or more sensitivities that were lost. The last study, 12% were lost. 28% had more. They gained reactivity, and cobalt was the most common one, and only half stayed the same. So we have some intrinsic variability in the patch testing. This is a biologic test, right? It's not like the ankle is broken, it's not broken. It's labile, and it's dependent on so many issues. So I might suggest that the dupilumab studies and the azathioprine and the cyclosporin may or may not be influencing this inherent variability. It got me so confused that how can dupilumab work for contact dermatitis. And yet studies demonstrating that you could still patch test for contact dermatitis, right? The recapitulation of the disease under test conditions, and to me, those were irreconcilable differences. You can't have your cake and eat it too, right? You might get better, and if it does work in contact dermatitis, it's going to affect the patch test results. It just will. So if we look at the top data from the North American contact dermatitis group, we see in the top 24 metals, isothiazolinones, fragrances, paraphenylenediamine, glycols, rubber, all of which may have different mechanisms of induction of allergy and elicitation on the patch test. So where do we stand with it? I'm going to layer in one more thing, which are botanicals, and you heard about them before. There are about 3,200 registered fragrances in the United States for use in products. And botanicals are unregulated components. I gave a talk in Colorado, and this was in the shower. And it got me aggravated, I got to tell you, right? Because look at this conditioner, just like Mother Earth used to make. Did I fall asleep during some asteroid that knocked out all the conditioner producing plants and trees on Earth? Never happened. It doesn't exist, right? There are no natural conditioners, right? You have to make them. And look at this shower gel. Shower gel's so green, you may grow leaves. I'm a simple guy from Brooklyn. I was pumping gas when I was 12 years old. I want to go in the shower, come out smelling better than I did when I went in. I do not want to grow leaves. I have no interest in that, growing leaves. Essential oils complicate this issue of mechanism even more, because we've discussed that this Th2 immunity on fragrances, but essential oils are very complex. If we just take, here, like Chanel No. 5 has Lang Lang oil in it, and these other essential oils, which are wonderful smelling and make us feel good, they're very complex. They're not a single agent. So Lang Lang has all of these chemicals in it, and some of them are rather potent sensitizers. So farnesol is a component of Lang Lang, and there's evidence that farnesol activates sensitization through Th1 pathways, not Th2 pathways. So it gets really complicated. I was in Kentucky giving a lecture, grand rounds, and this was the soap in the bathroom. You see this rum bar soap, 3% eau de toilette. I walked out of the shower smelling like I had an eye opener that morning, like I was nervous, I had some rum. I went to the university smelling like rum, and it made me very uncomfortable, I gotta tell you. But look at how many fragrances are in there. How am I gonna be able to detect whether a systemic agent is suppressing all of those? You don't. So flares, and this is probably the most complex part of the lecture because there's not a lot of data on this. I will tell you, for decades, it was dogmatic to believe that atopic patients were at lower risk and somewhat immunized from getting allergic contact dermatitis. And I could not figure out where that came from. And I went down this rabbit hole. That's when I was hunched over the computer, and I think I found where it started. On a Thursday in May of 1936, Marion Salzberg, I found the transcript of this. He presents at the American Medical Association his results of patch testing from 1931 to 1935. And he states at the meeting that nickel and arsenic had about the same frequency of reactivity in the contact dermatitis group versus the atopic dermatitis group, right? I'm not sure John Hannafin had convinced them of what those rules were for atopic in 1936, but they knew full well what atopic dermatitis was. But the other allergens were half as frequent. And so that's where I think this comes from, right? It starts here in those original patch tests. And then over the decades, this corroboration of this. Depression of cell-mediated immunity directly related to the severity of eczema. So this carried through for decades. And then what happens when you patch test and there's a little dermatitis on the back? Well, you can you can get pustular or patch test reactions, particularly to metals. Even if there's some follicular papules or a little erythema, the character of the patch test may look different. And finally, it gets us to a pragmatic approach because there is no data on this. So patch testing during atopic flares may decrease sensitization, but we have no idea what it does to elicitation, right? So maybe it affects you becoming allergic. We don't know if that flare is going to impact reading the back, right? But sometimes we have no choice. Concomitant systemic immunosuppressives, they may cause a problem. They likely cause a problem, but sometimes we have no choice. And when possible, you go to the lowest dose or you try to wash it out whenever you can. So I'm just going to conclude, systemic agents, whether they're immunosuppressives or immunomodulators, they are going to have an inherent hazard of false negatives, but there's some evidence that there's even the possibility of false positives. But we're stuck in situations where we can't get patients clear enough to test, and we have to put them on medications and test them while the getting is good, because the minute you take them off the drug, their back is filled with eczema. So we accept that risk, and we go on and we read into the milder reactions. And patch testing during flares is probably okay, right? You don't want the back to be so messy that you can't read anything. But I think if you wait for flares to resolve, those patients may be waiting weeks and months before you get your chance. So if there's a clear back or a clear flank or clear thighs, there's not a lot of evidence to suggest you shouldn't and can't go ahead and patch test. So thank you for your attention, and we look forward to the questions.